As well, we certainly encourage folks to chat among yourselves, and you can do that by using the chat button, typing in what you want to say to your fellow attendees, and then hitting send on that as well. Just a reminder, today's webinar meetup is sponsored by NISS, which is the National Institute of Statistical Sciences. NISS is a nonprofit national research institute for statistics. It promotes statistical research through postdocs, conferences and workshops, independent research, and a very active affiliates program. A few items coming up that are either hosted or sponsored by NISS are below on the slide. One is a course essentially in R and Spark as tools for data science workflows, and that's going to be instructed by E. James Harner. Dates at February 25th through 26th. And the second event is the 7th workshop on biostatistics and bioinformatics, which is sponsored by NISS as well in May. As always, to learn about these and the other events that NISS sponsors and runs, go to the NISS website and look under events. A reminder today is one of a series of virtual meetups hosted by NISS and Merck. I will remind folks at the end, but we've actually scheduled the next one, which is going to be April 1st, also in this time slot on applications of real-world data. But for today, the topic is statistical challenges in immuno-oncology. And the basic thing here is everyone knows that immuno-oncology is the study to develop and treatments that take advantage of the body's immune system. There's certainly been a lot of promise through the clinical results, and that has greatly energized the field of immuno-oncology. But there's also some very important statistical challenges in designing those studies and analyzing them. And today we have three fantastic speakers to talk to those challenges. First, Bo Huang from Pfizer will talk about quantifying the long-term treatment benefit with cancer immunotherapies. He'll be followed by Kong Chen of Merck on some adaptive design options for late-stage development of oncology immunotherapies. And then if all goes to plan, Andy Stone will be here to give some of his comments and then moderate the discussion. Okay, good. So let's get started with Bo's presentation. Bo is a director of biostatistics at Pfizer, and he's been there about 11 years. He currently leads a number of Pfizer cancer programs, and over the years has made significant contributions to the entire Pfizer oncology pipeline. He has been an active researcher and communicator with over 35 publications, 2 book chapters, and more than 40 external oral presentations and short courses. He's also on the board of directors of the International Chinese Statistical Association, and he received his PhD from the University of Wisconsin-Madison. So with that, let me pass the ball to Bo. And you're up, Bo.
Okay. So let me put it full screen. So thank you, Dan, for the introduction and for the opportunity to share some recent work on this important topic. So presentation, I would like to share some ideas on how to effectively quantify the treatment benefit with cancer immunotherapies, in particular the long-term treatment benefit, which has become a characteristic of immunotherapies. This is a joint work with Dr. Lu Tian and Dr. L.J. Wei. So how do I move it? Okay. So before my presentation, I also like to acknowledge some Pfizer colleagues for their input and for providing the data of some examples I use. Immuno-Oncology has been in the limelight over the past several years in oncology research and development. Even beyond oncology, immunotherapy is one of the most exciting research areas in drug development. For example, cancer immunotherapy was named by Science as the breakthrough of the year in 2013. And I like this quote from Michael Bloomberg: "Ending all cancer would rank among humanity's greatest achievements, and immunotherapy is bringing that dream within reach." Given the mechanism of action of immunotherapies, there are a number of challenges in clinical development from early phase to late phase. In the interest of time and to focus on the main topic of this presentation, I won't go into details of each of these. Some statistical challenges in early phase dose-finding trials are management of toxicity and dose optimization for single agent and combination therapies. While for late phase development, some challenges include non-proportional hazards due to delayed and long-term effect, weak or even negative correlation between progression-free survival and overall survival, and the selection of predictive biomarkers for design and analysis. Some of the challenges listed on this slide and previous slide are discussed in detail in a review paper published last year in Pharmaceutical Statistics. So the focus of this presentation is on the challenge of how to quantify the treatment benefit with immunotherapies. And later I want to introduce an alternative composite endpoint that could be useful in some situations. So first, let me describe some limitations of existing analysis methods. Although the log-rank test is non-parametric and does not rely on the proportional hazard assumption, it is equivalent to the score test in the Cox proportional hazard model. So it is optimal under the proportional hazard assumption, but may lose power if the assumption is substantially deviated. The log-rank test is an event-driven test, so the trial can be underpowered without enough number of events. And the test is not sensitive to flat tails of the Kaplan-Meier curves where there are few events. The interpretation of hazard ratio from the Cox model is not easy when the proportional hazard assumption is not true. And it is a relative measure of effect without indication of benefit in absolute term. On the other hand, the median is the most commonly used summary metric. However, statistically, it is just an arbitrary percentile and does not capture what's before and after, despite a good clinical interpretation. I want to show a couple of simulated graphical examples just to make these points more clear. So here is the Kaplan-Meier plot of a two-arm trial with hazards strictly proportional up to 20 months. If the hazards are also proportional after 20 months, as in the solid lines, the hazard ratio is a good relative measure of effect, and the median is a good absolute measure of effect. What if the curves are almost flat post 20 months, as in the dashed lines? Then the hazard ratio from the Cox model doesn't really change because there's almost no event after 20 months. And of course, the median does not change. So both scenarios lead to the same hazard ratio in the medians, but obviously they represent different patterns. Now let's look at a different situation. In the first 3 months, there's a delayed effect with treatment worse than control. But the trend is reversed afterwards with very low hazard rate in the treatment arm, and the constant hazard in the control arm up to 30 months, which deteriorates further afterwards. The median shows a detrimental effect, but clearly that doesn't capture the late benefit. The hazard ratio does show a positive effect, but it is not interpretable. And when we see crossing hazards like this, it is usually indicative of a substantial treatment by subgroup or biomarker interaction, but that's a different topic. In the literature, there are a number of alternative methods to the rank-based methods, including the T-time event-free probability, such as 1-year survival, 5-year survival, the win ratio method, the net benefit method, and the generalized pairwise comparison methods. The win ratio, net benefit, and the generalized pairwise comparison are similar in nature, and one can do a Google search for each of these methods. Another alternative method is the Kaplan-Meier-based method including the restricted mean survival time, the RMST, and weighted Kaplan-Meier-based test. The RMST is a method originally proposed a few decades ago for time-to-event analysis, but it hasn't gained much attention until in recent years. Quite a number of papers have been written in the statistics and the medical literature on theories and application of this method. The RMST has an intuitive and clinically meaningful interpretation. It is defined as the mean survival time up to a certain follow-up time, or truncation time, denoted as tau, which is equivalent to the area under the survival curve within the window from 0 to tau. If we use the Kaplan-Meier estimator for the survival function, then the RMST itself is non-parametric, and statistical inference can be done on the observed data based on some existing work in the literature. We can then measure treatment effect in terms of difference and the ratio in the RMSTs of different drugs. Compared to the hazard ratio, the RMST has good clinical interpretation regardless of whether or not the proportional hazard assumption holds. And it is non-parametric if you use the Kaplan-Meier-based method. It also has the capability of a dual presentation of relative and absolute effect in terms of ratio and the difference. Compared to the median and t-time event-free probability, the RMST is a more informative global summary, not just based on arbitrary percentile or cutoff. We can also look at the RMST curve as a function of the truncation point to measure the temporal profile by looking at different truncation points. I want to use the plot on the right as an example to illustrate this. So this is a phase 3 trial of inotuzumab versus control chemotherapy in acute lymphoblastic leukemia. If you look at the Kaplan-Meier plots, the proportional hazard assumption apparently does not hold. The top plot shows a median difference of 1 month. The bottom plot shows an area between the curves difference of almost 4 months, which turns out to be the mean difference between the two arms. So most people would agree that, in this specific example, the area between the Kaplan-Meier curves is a better global summary of the treatment effect, which turns out to be the RMST. There also seems to be criticism of the RMST method on the requirement of a truncation cutoff point. Some statisticians view it as a limitation of the method. It is a little bit ironic because everybody figures that out for RMST because of its name, including the word restricted. But few people seem to care that the same requirement is also applicable to other global summary statistics based on the Kaplan-Meier plots, including the hazard ratio, which is dependent on the follow-up time. As a matter of fact, the maximum allowed time window for hazard ratio and log-rank test is even narrower than that for the RMST. Under mild conditions on the centering distribution, one can make inference on RMST up to the last follow-up time, either event or censored for the arm with shorter follow-up. An asymptotic can be established, even though tau is a random variable here. In contrast, for hazard ratio and log-rank test, one can only use data up to the minimum of the last event time for any arm, the last follow-up time of the arm with a shorter follow-up. So looking at the same inotuzumab example from the previous slide, the window for hazard ratio log-rank test is up to a little more than 30 months, but the window for RMST is up to more than 37 months. So the RMST uses more information from the observed data. Okay, I think I have enough background information has been provided to lay the groundwork for what I'm going to propose for the second part of this presentation, a composite endpoint to measure the effect of cancer treatment, including immunotherapies. As cancer is evolving into a chronic disease for most indications, as clinical researchers and drug developers, we need to ask ourselves, what does a desirable future cancer treatment look like? First of all, it needs to be life-extending, and OS is always the gold standard. Second, there should be a high likelihood of tumor response defined as reduction in size. No patients want to carry a large burden of tumors in daily life. That's morbidity. Also, once receiving the drug, time to response should be fast, and the amount of time of being in the stage of tumor response should be long. That is, the response should be durable. So these three are the so-called imaging-based endpoints. Other desirable characteristics should include manageable side effects and improved and not worsening health-related quality of life. We would like to propose a composite endpoint that can effectively measure the three desirable outcomes based on tumor imaging. The natural question people will ask is, wait a second, for an imaging endpoint, don't we already have PFS, so why bother? Well, although PFS is a widely accepted intermediate endpoint, sometimes it has limitations. As we know, PFS measures the duration of disease stabilization, but disease stabilization may not translate to long-term survival benefit. Also, PFS cannot distinguish tumor reduction from no change or slight increase. If you look at the example on the right, patient A and patient B both had PFS of 12 months from treatment initiation. However, patient A's target lesions had a slight increase most of the time during the course. In contrast, patient B had dramatic reduction in tumor burden and achieved complete response after 6 months and had disease progression after 1 year on treatment. So both patients had the same PFS of 1 year. But from a clinical perspective, patient B had a much better outcome during this period. Lastly, although PFS enables us to design smaller and faster trials in the past, with cancer becoming a chronic disease, we will likely lose that capability. So this is a recent paper published in JAMA Oncology proposing an intuitive composite endpoint of duration response in the ITT population, not just for the responders. As a result, it enables us to do statistical inference between arms. I'm going to describe this method in the next several slides. The concept is actually very simple and intuitive by looking at 3 events of interest: response, progression, or death. In order to evaluate treatment effect of a drug, there are 3 states. State 0, which is time 0, the date of randomization of first dose. State 1, time 0 to response, progression, or death, whichever is earlier. And state 2, the time from response of state 1 to progression or death. From a therapeutic perspective, we want the time spent in stage 2 to be as long as possible. So the parameter of interest is the mean duration a patient is expected to spend at stage 2, which is from stage 1, the end of stage 1 to progression or death, before a truncation point. For the responders, this is equivalent to the duration response by traditional definition. The traditional method is conditional on response only. The mean duration response can then be defined as the expectation of the minimum of time to progression or death minus the minimum of time to progression, death, and response with a truncation point tau, and is equal to the area under the curve of PFS minus area of the curve for progression, death, response event-free within the window of 0 to tau. And it is equal to the area between the PFS curve and the progression, death, response-free curve within the time window. This can be interpreted as the expected duration of response up to a treatment for a patient receiving the study treatment. The variance term can be derived analytically or by bootstrapping, and the programming code is available at Dr. Lu Tian's website. Since this is an ITT analysis, it enables us to do statistical inference for cross-arm comparison. Here's an illustration of some possible patterns of time to response, progression or death up to a 30-month cutoff. So patient 1 had response at month 3 and then progressed at month 12. So this patient had duration of response of 9 months. Patient 2 has a response at month 9, and the response was ongoing up to the cutoff point. So with 30-month follow-up, the patient had duration response of 21 months. Patient 3 did not have response and progressed after 15 months, so duration response was 0. And the last patient, the patient did not have any of the events, progression, death, or response. So the duration response is 0. Here's a graphical example of restricted mean duration response. This is a tweet by Immuno-Oncology posted on Twitter after the paper was published online, illustrating the mean duration response for crizotinib up to 30 months in first-line ALK-positive non-small cell lung cancer. The shaded area between PFS curve and progression, death, response, event-free curve of crizotinib is the mean duration response in the ITT population by definition. To demonstrate the advantage of this method, a simulation study was done by looking at 2 scenarios. For scenario 1, a total of 400 patients is randomized to a 2-arm trial with a 1-to-1 randomization ratio. The ORR is 50% in arm A and 25% in arm B, so doubling the response rate for the new drug. Exponential distribution is assumed for time to response and duration response for responders and also for PFS. In arm A, the median PFS is 10 months for non-responders. For the responders, the median time to response is 2 months. The median duration response is 12 months. For arm B, median PFS is 10 months for non-responders. So for the non-responders, arm A and arm B are the same. For the responders, median time to response is 4 months, so 2 months longer than arm A. Median duration response is 8 months, so 4 months shorter than arm A. Uniform accrual is assumed, and accrual is expected to be completed within 12 months. And the analysis is conducted with a data cut of 25 months, 50 months, and 75 months from start of enrollment. And the truncation point is equal to the minimum of the maximum follow-up time of either arm. Scenario 2 is the same as scenario 1, with the exception of adding a cured effect. For both arms, it is assumed that 20% of responders have median duration response of 60 months. So that means 10% of all patients in arm A and 5% of all patients in arm B have long-term durable response with a median of 60 months or 5 years. And everything else for scenario 2 is the same as scenario 1. For scenario 1, at 25 months, for the PFS endpoint, the hazard ratio is 0.88. The median difference is 1.37 months, with the power only at 19%. With longer follow-up at 50 months and 75 months, the hazard ratio and the median difference are the same. If we look at the RMST of PFS, the difference is 1 month, 1.74 months, and 2 months with different follow-up time. So with longer follow-up, the effect size also increases for RMST. The power of RMST is similar to the power of log-rank test at each time point. Now, if you look at the proposed duration response endpoint in the ITT population, at 25 months, the mean difference is almost 4 months, larger than the 1.37 month difference in median, and 1 month difference in RMST under PFS. At longer follow-up of 75 months, the mean difference in DOR is 5.6 months, much longer than the median difference of 1.38 months and RMST difference of 2 months under PFS. The power is almost 100%, even at 25 months. This is because time to response is short, between a median of 2 to 4 months, and with a higher ORR in the treatment arm, a larger treatment benefit can be detected early based on the difference between 2 AUCs. If you look at scenario 2, there's a long-term treatment benefit with cured effect. It's a similar story. Hazard ratio and medians for PFS do not change with longer follow-up, and powers are low, more than 45% for the log-rank test. However, if you look at the RMST difference of PFS, the mean difference of duration response, it is a completely different story. At 75 months, we have an RMST difference in PFS of 3.4 months versus median difference of 2 months. And the mean difference in duration response is 7 months, more than triple that for the median difference in PFS. So for duration response, and if you look at power for duration response, it is almost 100%, regardless of follow-up time. So this simulation study demonstrates the potential benefit of using the mean duration response to quantify treatment effect by being able to capture higher response rate, faster time to response, and longer duration response. So in summary, with the emergence of novel therapies such as immunotherapies, conventional methods for time to event endpoints such as hazard ratio, median, log-rank tests may have limitations, although they are still valid in many cases, or in most cases. With cancer evolving to a chronic disease, the gold standard endpoint, overall survival, will be harder to meet. And PFS as a surrogate endpoint, despite its many advantages, still has limitations. With the advance of cancer treatment, including immunotherapies, it is expected that a higher proportion of patients will respond to treatment, with higher chance of achieving OR, CR, and durable response. So it's important to assess the drug activity based on these endpoints. Unlike oncology, in many therapeutic areas, the mean is the gold standard summary statistic, given the desirable statistical properties it has. For example, we know the sample mean is the sufficient statistic for a number of distributions in the exponential family. An intuitive analytical method based on the mean duration response in the ITT population was proposed as an alternative method for statistical inference to assess time to response, objective response, and duration response simultaneously, which can be a potentially useful and efficient method for the next generation cancer therapies. And that concludes my presentation. Thank you.
Thank you so much, Bo. That was great. Gave us a lot to think about and a lot of great information in there. I'd like to move now to Kong Chen's presentation. Kong joined Merck in 1999 with a PhD from Iowa State. He oversees the statistical support of early oncology at Merck and is currently executive director of early oncology. Prior to that, he led statistical support for pembrolizumab and played a pivotal role in accelerated approvals. He is an ASA fellow, also associate editor of statistics and biopharmaceutical research, and a veteran of more than 70 refereed papers and 9 book chapters. So with that, I pass the ball to you, Kong, and we're looking forward to your presentation.
Thanks, Dan, for inviting me to give this presentation. So I will discuss about a few penalty-free statistical design options for late development of oncology immunotherapies. And we all know we are kind of in the middle of the revolution of immunotherapy. And there are so many trials that have been conducted in recent years. If you look at the graph down, at the bottom, you notice that for each of those PD-1, PD-L1 drugs, there is substantial increase in number of trials that were conducted last year than the year before. And most of these trials are combinations. And a lot of these sponsors of these trials are intended to move those projects to late stage as fast as possible. And this has created an issue, which is that there is resource constraint and there is a tremendous uncertainty about the combination of this new drugs and whether they will work at all or whether they only work in the subpopulation that's identified by biomarker. And in this regard, to me, it's imperative to consider adaptive designs. Adaptive design has been a hot topic for many, many years, but in recent years, it's kind of people tend to be less enthusiastic because we are now trying to take in this immunotherapy field, people tend to just either do a phase 3 trial immediately without any delay or just to discontinue a project altogether. They tend to go to the extremes. And more importantly, I will talk about penalty-free design options to facilitate the adaptation of these new designs. And given the interest of time, I will focus on the so-called adaptive 2-in-1 design. And again, just to recap what I mentioned earlier, a status quo in early oncology to late stage transition for a lot of drug developers, a typical program tests a new drug combination with approved PD-1, PD-L1 in phase 1. And usually sample size is small, and once they believe they see a significant anti-tumor activity as compared to the standard of care, they will try to go directly to phase 3 and in hope to capture the market as well as to be competitive with other drug developers in the same field. This kind of practice, of course, has generated a few success stories. For example, in the case of Keytruda plus axitinib in first-line RCC, renal cell carcinoma, we observed a 73% response rate early on based on single-arm phase 1 study, and this compares favorably versus Sutent, which has a response rate about 31%, and the median progression-free survival in this single-arm study was about 21 months versus 11 months. 11 months for Sutent, and to add to that, both drugs as monotherapies are known to be active in RCC. And the subsequent phase 3 study was a tremendous success. It stopped early for overwhelming survival benefit at the first interim analysis. For every success story, we always have a counterexample, and in this case, avocadostat, which is the ideal one, was tested in melanoma, first-line melanoma actually, and at the time it was considered the most advanced new mechanism of action right after PD-1, PD-L1. There was a lot of hope that this drug, when combined with those PD-1, PD-L1s, can generate additional benefit. And in the phase 1 single-arm setting, the drug actually didn't disappoint in terms of the empirical data, whereas it showed a 56% response rate, which again compared very favorably to pembrolizumab alone, which generated a 37% response rate. However, the subsequent phase 3 study was a failure, so much so that there was actually no treatment effect at all based on the empirical Kaplan-Meier curve. As a result, this drug, the development of this drug was terminated for pretty much all the indications except for probably 1 or 2. And this was considered a major setback in the IO space post the PD-1, PD-L1. So if we step back and think through the process, what are the real options we have post the phase 1b efficacy expansion in the phase 1 trial after a dose is found? Usually, if the drug is indeed so outstanding, especially when the test drug has as a monotherapy is also active, is known to be active, which gives you confidence that the combination data you see from this kind of a phase 1 study may present an improvement over the standard of care option is available to go to phase 3. Granted, even in phase 3, you probably want to add some risk mitigation strategies such as futility look, etc. And another option, of course, is the traditional phase 2 followed with a separate phase 3, which is a approach that nowadays nobody likes to take. But really, in the middle, there is something called 2-in-1 design, which allows you to start the program as a phase 2, but you do have option to expand phase 3, and the phase 2 data that you used for making such a decision will also be included in phase 3. And under this 2-in-1 design, you can have even more option, 2 more sub-options for the phase 2 part, depending on whether phase 2 can be used for potential accelerated approval filing or not. And the paper is published last year. So this is just a framework of a generic 2-in-1 design. You start with a phase 2 randomized trial after you observe exciting signal in phase 1b based on single-arm study. And then you, in this randomized setting, you test whether the signal you observed in phase 1 is for real or not, based on endpoint that you believe give you confidence to start phase 2 in the first place. In oncology, is usually response rate or tumor reduction, or for this matter, it can be a duration of response, as Juan has presented. And if you do see this kind of if you don't see this kind of exciting signal in the randomized setting anymore, you keep your trial as a phase 2. But if you kind of confirm the signal, you expand phase 3. And the beauty of this 2-in-1 design is that whether you expand or not, you can always declare success. And further, as I alluded earlier, if you expand phase 3, the phase 2 trial data that you used for the decision making can be included into the phase 3 final analysis. And the 3 statistics, standardized test statistics, X, Y, and Z, can be based on different endpoints. And in the usual case, when X and Y are based on the same endpoint, for example, response rate, the type error rate of this design is controlled, meaning that W can be 1.96 to keep the overall type error rate controlled at 2.5%. And the requirement for X and Y to be the same endpoint is sufficient, but it's not necessary.
Kang, this is Dan. I don't want to interrupt, but we have a couple of people having a little trouble hearing, so if you could speak up a little, that would be helpful. Thanks.
Okay. And before you conduct a 2-in-1 design, you should ask yourselves a few questions. First of all, should you consider randomized phase 2 instead of a straight phase 3 based on the promising phase 1 data? If the answer is yes, you may consider such option. And secondly, if the whole program is ready for registration enabling study, because once you get on this track of a 2-in-1 seamless phase 2/3, it's hard to get off. And third but not least is that whether logistics can be worked out to ensure a seamless transition. And if the answers to all this are positive, you are actually at at the door of considering such a design option to benefit and also to mitigate your risk of the phase 3 program. So this is just an example, which is based on our experience. We have a phase 1 small trial of a combination therapy with standard of care, which demonstrated exciting overall response rate in first-line gastric cancer setting, and actually it's in a biomarker identified population. And we decided to add more patients just to quantify better the response rate. But again, since it's in the single arm setting, no matter how many patients you add, you always have uncertainty whether this signal is true or not, especially given that it's based on a biomarker subpopulation that's historically less studied in the literature. And meanwhile, a similar phase 2/3 trial based on the 2-in-1 design was considered. The phase 2 part in this case was oversized for the possible filing for accelerated approval. And the expansion decision from phase 2 to phase 3 targets 1 month ahead of phase 2 accrual completion, so that the seamless expansion can be realized once a decision is made at the time that all the patients for phase 2 are enrolled. So this is just to provide some more design details. So for the phase 2 part, it's a 1-to-1 randomization of 240 patients. With this sample size, has 88% power for detecting ORR increase of 20% at the 2.5% level. And since it's oversized, we did add a futility check just in case, in case of no ORR improvement, the trial will be stopped early for futility at about 160 patients also. And the p-value for ORR less than 0.025 will lead to a filing for accelerated approval. But in case of no expansion to phase 3, and if a p-value didn't meet this bar, but the totality of data is still positive, a separate phase 3 trial may be considered, and which basically gets the program back to the kind of conventional strategy, conventional approach. In case of expansion, additional 360 patients will be enrolled, so that together this trial will be 600 strong, and we will target to have 460 OS events. With this number of events, it has 90% power for detecting hazard ratio of 0.74 at the usual 2.5% level. And again, a p-value less than 0.024, 0.025 will lead to the filing for full approval. And one thing I need to emphasize is that the type I rate is always controlled for any expansion bar. You don't, as long as, of course, you should specify upfront instead of doing that after you look at the data, just to keep the integrity of the trial. And in the next 2 to 3 slides, I will talk about one option, one way to optimize this bar. Of course, in reality, you can have different approaches to do that. The specific method I'm talking about, I'm going to introduce, is called benefit cost ratio analysis, which basically tries to maximize the benefit cost ratio in order to derive this expansion bar. The benefit here is very simple. After consulting with marketing and clinical, etc., we decided that a positive phase 2 trial may be worth just 1/3 of a positive phase 3. This is just our base assumption. I will show the sensitivity to the assumption later on. And the cost, can be reasonably well predicted ahead of time because we know that the phase 2 part will have 240 patients, and the goal decision will trigger the accrual of another 360. And for illustration purpose, I didn't use the actual cost structure, but just to use a sample size as surrogate to measure the cost. Overall cost, apparently, of this problem is 240 plus plus the probability of a goal decision multiplied by 360, and the goal decision can be made right or wrong. And for this, our base assumption is that the drug has 50% chance of being active and a 50% chance of being inactive. So basically the drug has equal chance to be null or alternative in terms of treatment effect. And the bar of expansion is optimized by maximizing the benefit over cost. And the work is being reviewed for publication. So this shows you the benefit cost ratio, how it changes with the expansion bar. The expansion bar is just a numerical difference between treatment arm and the control arm in terms of the ORR. And the negative value means that you go even if you the experimental arm is doing worse than control arm. So in comparison, we also provide the BCR for the phase 3 trial, direct phase 3 trial, which is in dotted line. So for the phase 3 trial, without any gatekeeping, the BCR is of course just a constant. But for the adaptive design, 2-in-1 adaptive design, the BCR changes with the bar, and which is in a solid line. And when the bar is very low, effectively you are kind of you basically go to phase 3 regardless. As you can imagine, the solid bar and the dotted bar, the solid line and the dotted line overlaps. And on the other hand, when you raise the bar to be so high, you kind of lose the benefit of a phase 3, a positive phase 3 trial, and as such, the BCR is actually lower for the 2-in-1 design as compared to the straight phase 3 trial design, and somewhere in between. In this case, it's at about 11%. You realize the maximum benefit of this 2-in-1 design. So this shows you the sensitivity to the input variables. Of course, we don't know the truth about the treatment effect, and our assumption is that it's equally likely to be at null and at alternative. But if you change these numbers, whether the bar changes accordingly, how much does it change? And another thing is relative value of positive phase 2 versus phase 3. We use 1/3 as kind of a base assumption, and we also tried different numbers like 1/5, etc. And as you can tell, the approximate optimal expansion bars change accordingly to the direction as you expected. But in general, it looks like a 10% difference is something that you should observe in order to make a good decision. And this bar is reasonably insensitive to those parameters. Now, for the interest of time, I will also introduce a few other options, specifically for phase 3 and with a focus on biomarker consideration, because a lot of drugs we are developing in oncology tend to work better in a biomarker subpopulation, biomarker positive subpopulation than a biomarker negative population. And for simplicity, I will just consider that all common population it consists of two subpopulations, one biomarker positive, one biomarker negative, and these are all pre-specified and predetermined without any ambiguity. So let's consider a scenario when you have an investigational new drug that showed a similar overall response rate to standard of care in the phase 1 setting, but the response rate seems to be much higher in the biomarker positive population, which gives you confidence that the drug may be working in the biomarker positive population, if not in the all-comer population. But again, since the standard of care is not used in this phase 1 setting, and there is great uncertainty about this conclusion, and further, we don't know whether the response, how response rate correlates with survival. It may be that there is some kind of delayed effect, such a similar response rate may for the IO may actually improve the survival as compared to standard care. But with this all considerations, it's justifiable to initiate the biomarker-enriched study first, and the study will have option to expand to all comers if data is more promising than expected, which suggesting broader activity. So basically, you take a look at the interim data and compare the biomarker, compare the experimental arm versus standard of care in terms of the response rate or whichever endpoint that you think can be predictive of survival. If it turns out that the treatment effect actually is even greater than you observed at the phase 1 setting, and you try to start to accrue all-comer population, and otherwise you stay with this biomarker positive population. If you do expand, the hypothesis will become such that will be revised such that a win in the biomarker positive population or a win in the all-comer population is a win, and you can use Bonferroni to split the alpha. And one benefit of such design is that if indeed you go to this all-comer population, the patient you have the chance to declare success in both ways. And to make the all-comer population a bona fide population, the previous patients that you used for decision making shouldn't be included in the analysis of the all-comer population, which has to be based upon all those that are enrolled later. But if you don't, but in that case, you still can use can include the biomarker positive population in the biomarker positive analysis. And it turns out that this kind of design actually is valid, and the publication is also in last year's contemporary clinical trials. And then this is a second different scenario, whereas you have an investigational new drug improved overall response rate over standard of care in both biomarker and biomarker positive, biomarker negative population, but there is some indication that the drug may be more active in biomarker positive population relative treative or standard of care for a future phase 3 trial. And in this case, all-comer phase 3 trial is initiated, but is stratified by biomarker status, so that a win in the all-comer population or a win in the biomarker positive population is a win. But you can do an intra-analysis at the of the biomarker negative population during the trial, and if it turns out that the biomarker negative data is less positive, less impressive for the experimental arm, which suggests that the drug may not be as active as you hypothesized, and in this case, you can hedge upon the biomarker positive population by adding additional patients in biomarker positive group, and it turns out that such a design can also work without paying a penalty. Of course, if the biomarker during the intra-analysis, if the drug has evidence to be not working at all, you can call it quit earlier. And these are just additional kind of features that can be added to this kind of design. And in the last example, I will discuss about the scenario where it's of interest to test the monotherapy of investigational new drug versus standard of care in a biomarker positive population. And meanwhile, you are also interested in testing the combination therapy versus standard of care in the all-comer population. And traditionally, when you have this kind of scenario, you conduct two trials. One is new drug versus standard of care in biomarker positive population, and the other, of course, just the combo versus standard of care in all comers. And the disadvantage of doing two trials in the conventional approach is that you will have to those trials will have to enroll biomarker positive patients to the standard of care arm, and given that you already know, or at least you have data to suggest that these patients are better off to stay in the experimental arm or the combination arm, it becomes less ethical and less efficient, and especially when the biomarker prevalence is low. So there is an option to do it in single trial, which is to stratify by the biomarker status first. And for patients in the biomarker positive strata, you randomize a three-way, 1-to-1-to-1 to mono, to combo, and standard care. And in the biomarker negative population, you only randomize into combo versus standard care. So when it comes down to comparison between combo versus standard care, you pull data across the two strata, but when you analyze data between mono versus standard care in biomarker positive population, you just look at the patients in the biomarker positive strata. And this kind of a chart raises a natural question, which is how to make sure that your comparison between combo versus standard of care is in a bona fide all-comer population, because after all, for the biomarker positive patients, due to the three-way randomization, the kind of prevalence is diluted. But fortunately, this dilution is predetermined and is fixed. So what you do is to adjust the data from this biomarker positive population accordingly by the randomization ratio. Basically, you give these patients in the biomarker positive population 2/3 of the weight, but the patients in the biomarker negative population have the full weight. And then this way you can combine the data between these two strata and to have a fair comparison between the combo versus standard care in the all-combo population. And this work is being prepared in a manuscript as we speak. So as the first discussion point, I was kind of alluding to during the talk, additional features such as futility analysis can be included in the all those designs I talked about. Other features such as group sequential design and the inclusion of co-primary endpoints can be also included. And it's sufficient to say, since this trial designs kind of new, more research is warranted, especially on how to implementing in the real-world setting, given all those considerations. On one hand, I feel like I'm introducing some new design methods, but I think my real purpose, if any, is to actually motivate you guys to take advantage of this new era of immunotherapy, which in my mind really opens the door for statisticians to not only develop new analyses and design methods, but also to get you opportunities to involve in the strategic decisions, because there are so many issues that are unknown at the planning stage of this phase 2/3 programs, mainly surrounding the probability that the drug is even working or not, or for this matter, whether the drug activity is in the biomarker subpopulation or not. And meanwhile, the sponsors all try to develop try to be cost effective, given the fact that they have so many competitions and competitive products, and also they wanted to be fast, given the competition. How to balance all those considerations, which to me give us again opportunity to not just be able to provide some operating characteristics of designs that the clinical people have come out, but also to help them to design the whole program from a strategic point of view. And the designs I provided today are just not meant for you to immediately apply to your work in the sense that in reality situations differ from one trial, from one setting to another. You always have to better understand the real issue in order to come up with the best strategy to the designing of your trials. And in this sense, there are always creativity that you can apply to your work, and so that the program you have to develop is the most reasonable and most cost-effective. With that, I conclude my presentation, and thank you for your attention.
Thank you so much, Kong. That was great. In the interest of time, I want to move straight along to the discussion. We're lucky to have Andrew Stone from Stone Biostatistics. Andrew has more than 25 years in the pharma industry, led the oncology therapeutic area for AstraZeneca for about 10 years, has a lot of regulatory experience, including submission or approval of 6 different products, and like our other panelists, is a recognized expert and widely published in the area. So with that, I'd like to move to you, Andy, and so your comments and then some questions.
Can you hear me, Dan? Am I off mute now?
I can hear you fine, yes, thank you.
Okay, yeah, I'll just, I'm in the interest of time, actually, let's go straight to the discussion. I mean, 2 excellent presentations, you would imagine, from such well-respected and well-known speakers. Bo gave us a really great overview of the issues that we've got with these therapies, and looked at the concept of expected duration response. And then Kong this gave us this intriguing 2-in-1 design, and then talked about biomarker designs. And I've seen there are some questions come in for you, Kong, already on some of your slides. They're quite specific, so let me just ask the 2 speakers their thoughts on one more general question, and that is, neither of you covered it specifically, but there's been a lot of discussion, stuff in the literature about alternative analyses for these endpoints that weight events differently. Because if you knew the curves were going to open up, you could weight the tail of the curves at the end, and it would be more powerful than the log rank or COT. But I wonder, whilst that's something we could do, I wondered whether Kong or Bo, you wanted to comment as to whether you think that is appropriate, or specifically it's appropriate to weight different patients differently.
Yeah, so I think this is a great question, and this pretty tricky because different people have different opinions. To some people, weighting events or even Kaplan-Meier statistics unequally, that is overweighting some and downweighting the others, implicitly regards the extension of life as being more important for some patients than the other. So this may cause an ethical concern, as you just pointed out, even if there may be a potential increase in the statistical power. So there's actually a cross-industry FDA non-proportional hazard working group established 2 years ago with members from all major pharmaceutical companies and the FDA. And the team did a lot of work, including simulations, and they proposed a method called a maximum combination test, which is basically diagnostic test by looking at weighted log-rank test with different weights. So this is a method the team think that could potentially improve power. And there was a presentation, there was actually a workshop last year, in February last year at Washington, D.C., at the Duke Margolis non-proportional hazard workshop. And all the materials are available to the public on the website. And the 8-hour presentations were also recorded and available to watch. So, I don't have a, I don't want to, give a definitive answer because, it is really subjective. To a lot of people, improving power is more important than interpretation or ethical issue. But maybe to others, they can have a different opinion.
Okay, thank you, Bo. Kong, do you want to comment?
Yes. So to add to both comments, I think we should also try to identify the root cause of such a phenomenon, and it could be just that there is certain population that the drug works better than the other, or could it be that the prognostics of one population, one subpopulation, and the other is so different that you have this kind of artifact. So in this regard, some kind of stratified analysis may be more helpful, and even onto the traditional assumption of proportional hazard ratio. And another thing I wanted to point out is that oftentimes this kind of phenomenon may be more often seen in monotherapy versus standard of care. But if it's combination, at least so far we have lesser issue. And given the fact that in future it's more about the combinations than the monotherapy, the concern, if any, may automatically be less moving forward. And last but not least, I want to comment about the power. I know there are concerns about ethical or philosophical whether it's appropriate to weight certain patients more than the other. But also we have to balance the fact that if we can clearly demonstrate the benefit of a drug earlier with fewer patients, eventually it's beneficial to the patient society, and so we also have to balance that. So that's these are the thoughts I have.
Okay, thanks, Carl. I mean, my own views. I agree certainly with the statement that you need to assess whether you can identify a particular group of patients, and that's the explanation. But personally, I have a very strong view that we should be weighting events equally, because I struggle to see why it would be appropriate. You know, why unless we have with evidence of a cure, I think that changes things substantially. But if that's not the case, then I struggle with why we think it's more important to extend the life of some patients rather than others. But I do know people have very different views on this, and I think at the very least, when we present such work to the medical community, the consequences should be spelled out and it be completely crystal clear as to what the consequences are of choosing an analysis that we think will be more powerful. But let's turn to a different question. We have some questions on there, and encourage people to put further questions through while we're covering the first ones. But I'll pick up one. I don't know whether you can see. It's quite a specific question, and it relates to in the case of no expansion. There's a question here. Well, given there's an interim analysis going on, why do we not need a multiplicity adjustment? I'm guessing it's something to do with the fact that it's a futility analysis, but I'll let you pick that one up.
So what's the question again? You mean?
Oh, can you see, if you go to the bottom right-hand panel, you can find the specific question. So I'll read it. In the case of no expansion, the interim occurs before or after the analysis for expansion decision. Do we need to consider a multiplicity for this interim of phase 2? So I think it's, if you don't expand, given that there's an interim in that phase 2, why is there not a multiplicity adjustment?
Yeah, actually we don't need to. So the explanation can be found in the paper, of course. I guess it's too lazy explanation, but the bottom line is that the decision of expansion or not, if you think about it, it's more or less like a futility analysis in some sense. When we do the futility analysis, in this case, it's kind of binding futility, and there's naturally some kind of error that's not used. And this kind of design, in this, basically takes advantage of that in this regard. But then it expands beyond the traditional futility analysis, because the traditional futility analysis is usually based on the same endpoint, etc. This gives the option to use any endpoint and also describes a more general mathematics design, and the option, more importantly, fits into this kind of current environment of expedited drug development.
Okay, thanks, Con. Dan, have we got a hard stop at 15:15?
Since there are a few more questions, why don't obviously, since the webinar folks can drop off as they want, let's answer one more question and then we'll wrap it up.
Yeah, maybe just one question if you don't mind, Con. And I've wondered about this 2-in-1 design because I think it's a great idea. Does that cutoff, presumably that needs pre-specifying ahead of the analysis, and presumably better if that's in the protocol. You can't, so for example, you can't decide that cutoff having looked at the data.
Right. You do have to pre-specify such a cutoff right before the analysis. So ideally, you pre-specified it in the protocol from the get-go. But anytime if you haven't looked at the data yet, you can always based upon competitive intelligence data or based on blinded trial data to make a decision, and well documented up ahead of the analysis. Just like any adaptive design, pre-specification of the criteria before the actual analysis is important.
Okay, thanks, Tom. So I think we'll wrap it up there. Sorry, there was one other question that came through that I missed on the Q&A. So apologies to the person who posed that. We haven't covered it. But so over to you, Dan, to wrap up the meeting.
All right. Well, thank you for leading the discussion. I first want to well, I want to thank the speakers, but before I do, a number of people are asking about the slides, and we'll make the slides as well as a recording of the meetup available at the NISS website. So you'll see the previous ones, and you'll see the one for today's meetup. So I just want to make sure to get that out there. First, I want to thank, obviously, the speakers and Andy for being our discussant. You guys did a great job. It's certainly a very challenging but also an exciting area for statisticians, and it's an exciting time to be part of all that. So thank you to all of you for being part of it. I also want to thank Christy Trang-Stein, who helps me organize these things, as well as Kara, who helps me with the technical stuff. This session actually was a result of some of the input from the survey, so please take it. It's very short, as well as Lingzhao Zhu, who had the idea of talking about immunotherapy. And then one last reminder that our next meetup is going to be scheduled for April 1st. It'll be announced on the website, as well as the usual channels of ASA Connect in the Bioform section. So with that, again, thank you to everyone for your attention and for participating, and we'll look forward to seeing you next time.
Thank you, Dan.